Hello everyone, and welcome to our weekly podcast brought to you by VJOncology. This week, we will be covering updates from the 2026 AACR meeting. First off, we have Kristen Pauken from the University of Texas MD Anderson Cancer Center, who discusses the challenges associated with immune-related adverse events following checkpoint immunotherapy.
So the talk that I'm going to be giving for AACR is in a special session that's focused on immune-related adverse events that occur following checkpoint immunotherapy. So obviously, checkpoint immunotherapy has had a tremendous impact on how we treat cancer, leveraging the immune system to go in and attack cancer instead of going after cancer directly. But what we've seen in a subset of patients is that we sometimes will get these off-target side effects that in many ways look like autoimmune diseases or autoimmune-driven pathologies. And we call them immune-related adverse events, or IRAEs. And these are toxicities that are directly attributed to boosting the immune system, but that immune system having these off-target effects. And so what I'm really trying to focus on in my talk is identifying some of the major research bottlenecks that the field is struggling with. And overcoming some of these bottlenecks, in my opinion, is really important for improving kind of how we assess risk for developing these events, how we diagnose these events, and then how we treat these events. And so the focus of my talk is going to be on this issue of where the immune cells are actually coming from that are causing the problem. And there's sort of two opposing models. One is that the immune cells that are causing the toxicities are actually already there in those organs in patients at the time that we start treating with checkpoint inhibitors, and that just unleashes those cells in those areas to cause tissue damage. The alternative is that those pathogenic cells were actually not in those tissues at the time of treatment initiation, and rather they are triggered in other parts of the body to migrate into the tissue. And being able to distinguish between whether it's cells that were already in the tissue or cells that have migrated in the tissue is really important, both in terms of how we monitor, but also how we treat. So if it is migration, then monitoring perhaps in the peripheral blood could be really useful, because the blood is this major superhighway between things like lymph nodes and spleen and bone marrow and these peripheral tissue sites where we see the toxicity. But if they're already in the tissue when we start treating, then perhaps monitoring in the blood will be less useful. Similarly, in terms of how we treat, if migration is important, we can think about using the arsenal of immunomodulatory drugs we have to block cells from getting into tissues. The gut is a great example, because blocking the integrin alpha-4 beta-7 can be very effective for keeping cells out of that tissue. And there are clinically approved alpha-4 beta-7 inhibitors. But as you could imagine, if the cells are already in the tissue, then blocking migration is going to do nothing. And so really understanding where these cells are coming from is super important. But in our translational studies, actually definitively determining whether or not it's migration versus residence has been really challenging. And so kind of discussing the challenges there in terms of asking that question, as well as kind of areas of the field that I'm hoping are going to be evolving with preclinical models to be able to kind of address where those cells are coming from. I think there's still a lot of question marks in terms of whether or not the cells are already in the tissue at time of treatment or if they're migrating in. And if we can figure that out, then that is going to hugely impact how we monitor and how we treat, in terms of thinking about different biologics we could use, or, certain types of immunosuppression, or, systemic versus targeted therapy. And so I think answering the questions are really important. And just based on where we're at as a field, I'm actually going to be kind of presenting more questions that we have than answers in my talk. But I'm hoping that by kind of vocalizing where I see the major research bottlenecks are, we'll be able to kind of start thinking creatively as a field to try to overcome those limitations.
Next up, Timothy Yap, also from MD Anderson Cancer Center, provides an overview of early findings from the first-in-human phase 1 study of PLN 101095 with or without pembrolizumab in advanced solid tumors refractory to prior immune checkpoint inhibitors.
I had the privilege of presenting data from the first-in-human phase 1 study of PLN 101095, which is a first-in-class dual AV-beta8 and AV-beta1 integrin inhibitor, given both as monotherapy and also in combination with pembrolizumab in patients with advanced solid tumors refractory to immune checkpoint inhibitors. The whole scientific reason for this particular trial is that in response to sustained immune activity, solid tumors utilize integrin AV-beta8 and AV-beta1 activation of TGF-beta to suppress and escape immune control. And therefore, PLN-101095 was designed to potently block integrin AV-beta8 and AV-beta1 driven activation of TGF-beta locally in a tumor microenvironment. And this is different from past strategies of systemically targeting the active TGF-beta cytokine, the TGF-beta receptor kinase, or specific isoforms of TGF-beta. And PLN-101095 selectively enhances T-cell interferon gamma effector function. It reduces fibroblast activation and fibrosing tumor stroma, and therefore inhibition of integrin AV-beta8 and AV-beta1 blocks the activation of TGF-beta to really reduce immunosuppression, leading to a new or reinvigorated cancer immune response. And overall, by inhibiting TGF-beta, PLN-101095 shifts solid tumors to a high interferon gamma signature and an immune checkpoint inhibitor responsive state. That provided the rationale to proceed to this phase 1 open-label dose-escalation trial in patients with solid tumors with prior immune checkpoint inhibitor resistance. All patients were mandated to have prior exposures to PD-1 therapies with documented disease progression and were required to have primary or secondary resistance by SITC definitions. The primary and secondary endpoints included the assessment of safety and tolerability and also pharmacokinetics, whilst the exploratory endpoints included anti-tumor activity and changes in blood-based biomarkers. We explored different dose levels, ranging from 250 milligrams BID up to a top dose of 2,000 milligrams BID of PLN-101095, given as monotherapy and in combination with pembrolizumab. Overall, we treated a total of 16 patients during dose escalation. It was well tolerated, and the most common treatment-related adverse event was grade 1 to grade 2 rash. There was one treatment-related rash that was reported during the monotherapy period, but otherwise the rash was primarily observed within 2 days of starting combination therapy. In terms of pharmacokinetics, the PK profile supports continuous pharmacologic inhibition with BID dosing at steady state. And importantly, anti-tumor responses were observed in patients with secondary immune checkpoint inhibitor resistance, including 4 patients with iRECIST responses, including 1 complete response, 2 partial responses, and 1 unconfirmed partial response. In immune checkpoint inhibitor secondary resistance patients, the overall response rate was therefore 30%, with a disease control rate of 60%. Overall, we observed clinically significant and durable responses in 3 out of the 4 iRECIST responders at doses of 1,000 milligrams BID of drug or greater. And the median time on treatment was 19 months for the 3 confirmed objective responders who had an average maximum target reduction of minus 89%. Interestingly, we also observed that increases in interferon gamma during monotherapy may actually act as a potential biomarker of TGF-beta inhibition. We saw that clinical responses to PLN-101095 was associated with elevated plasma interferon gamma and PD-L1 levels after just 14 days of PLN monotherapy. And this will be studied further in our dose expansion cohorts. So to conclude, PLN-101095 was generally well tolerated in this dose escalation part of this phase 1 trial, with no new safety concerns emerging when this integrin inhibitor was combined with pembrolizumab. Importantly, Early signals of anti-tumor activity were observed in patients with immune checkpoint inhibitor secondary resistance, with an overall response rate of 30% and a disease control rate of 60% when treated with PLN-101095 plus pembrolizumab. Circulating interferon gamma may be a potential biomarker for early prediction of treatment response, and dose expansion cohorts are planned for initiation in the second half of 2026. These data for PLN-101095 plus pembrolizumab suggest the potential to meet a high unmet treatment need amongst these patients with secondary immune checkpoint resistance with no new safety concerns. Thank you very much.
Following on, Bruno Bockorny from Beth Israel Deaconess Medical Center discusses interim results from a first-in-human phase 1 dose-escalation trial of denikitug in advanced solid tumors.
So at AACR, I will present the preliminary result of the phase 1 first-in-human study with this anti-CCR8 antibody called denikitug in patients with advanced solid tumors. So the rationale for this study is this: regulatory T cells or Tregs, they are major drivers of immunosuppression within the tumor microenvironment, and their accumulation in the tumor is actually associated with worse outcomes across multiple tumor types. So we have this drug called denikitug, which is an engineered monoclonal antibody specifically designed to target these CCR8 positive intratumoral Tregs. And this antibody was designed in a way to go after the intratumoral Tregs only and not so much on the peripheral Tregs, minimizing adverse events. The phase 1 was a large study with two major components. One to evaluate denikitug as a monotherapy, and the other, denikitug combined with an anti-PD-1 inhibitor. For AACR, we'll be presenting the data of the monotherapy cohorts, Part A and Part B. There was a dose escalation initially, and then a subsequent cohort where patients received doses of 10 milligrams and above. And we were also able to obtain pair biopsies to understand the immunobiological effects that denikitug was causing the tumor microenvironment. Moving to safety, overall, the safety profile of denikitug was manageable. The main adverse events that we saw were immune-mediated skin rash and pruritus, also some diarrhea, mainly grade 1 and 2. Grade 3 adverse events were uncommon. And overall, we think this profile is very consistent with the immunomodulatory mechanism of action of Treg depletion. Now, turning to efficacy, it's important to point out this was a heavily pretreated population, and 2/3 of the patient had prior exposure to anti-PD-1 or anti-PD-L1 therapy. Within the 52 evaluable patients, we saw objective response rates of 8% and a disease control rate of 46%. I will note that responders had a median of 6 prior lines of therapy, so heavily pretreated patients, and the responses were also durable. The median duration of response was 4.3 months, but ranging up to 14 months. And in terms of the immunobiological effect, we were excited to see that the drug was doing exactly what it was designed to do. After 2 doses of denikitug, we saw actually major depletion of the intratumoral Tregs and a concurrent increase in expansion and infiltration by CD8 positive effector T cells.
Finally, Byoung Chul Cho from Yonsei University in Seoul, South Korea, comments on updated results from the phase 1/2 trial of elisrasib monotherapy in previously treated KRAS G12C-mutant non-small cell lung cancer.
So elisrasib is a next-generation KRAS G12C inhibitor designed to maximize target engagement and outpace growth factor stimulated GDP and GTP exchange. So in our phase 1/2 study, we enrolled patients with locally advanced or metastatic KRAS G12C mutant solid tumors. And in phase 2, expansion cohort, we enrolled both G12C inhibitor naive and refractory NSCLC population. So in our study, we observed a confirmed objective response rate of 52% and disease control rate nearly 100% in 600 milligram QD, of which was the RP2D. This was the confirmed objective response rate in G12C inhibitor naive patient population. And regarding duration response at 600 milligram QD dose, median duration of response was 16.5 months, and median PFS was 12.2 months. When it comes to efficacy in G12C inhibitor refractory population, response rate was 32% in G12C inhibitor refractory NSCLC population. And then median duration of response and median PFS in this refractory population was 15.6 months and 8.1 months respectively. Because we showed objective response rate 30%, which was durable in refractory population, elisrasib may be a potential therapeutic option in patients who progress to a bearable G12C inhibitor such as sotorasib or adagrasib. More importantly, because elisrasib showed very potent efficacy in G12C inhibitor naive setting, which was far more potent than those from sotorasib or adagrasib, first generation G12C inhibitor. I believe elisrasib is a best option, one of the best option in G12C inhibitor naive setting, and among all other next generation G12C inhibitor, elisrasib showed high efficacy with a very good safety profile.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favorite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.